This episode of Pupil Pod is supported by Dompe.
Welcome to Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Neda Shamie. Dr. Shamie is a cataract, cornea, and refractive surgeon based out of Los Angeles, California, and I am so excited to have her on the podcast today. Dr. Shamie, thank you again for joining me.
Thank you so much for having me. I wish I had access to something like this when I was at your stage, but I'm really delighted to be here. And Sila, you are really such an incredible colleague. I look forward to seeing your career evolve and grow, and so excited to know you.
Thank you so much. You already know how I feel about you and your mentorship, so thank you again for joining me. Let's get right into it. This case is of a 68-year-old man with no past ocular history who is referred to your clinic from optometry for cataract surgery. On examination, his best corrected visual acuity is 20/50 with a decrease to 2200 OU on glare testing. He has bilateral 3+ nuclear sclerosis, and you determined that he is a good candidate for cataract surgery. When you discuss lens options, he states that it is very important for him to have good intermediate and distance vision. Now, Dr. Shamie, before we get into the details of lens options for this specific patient, could you please give us a brief review of the Helmholtz theory of accommodation?
Yes, of course. And, I have to admit that this is something that you stop thinking of when you're actually in clinical practice, but you absolutely need to, like much of what you need to know for the boards and for the caps and such. But having said that, thankfully, I still remember. So basically, the theory of accommodation, there's multiple different theories, but probably the most popular is the Helmholtz. And that is that during accommodation, the ciliary muscles contract and cause relaxation of the zonular fibers, which then essentially changes the lens curvature, the anterior and posterior lens curvature in a healthy and younger lens. And by doing that, the power of the lens then increases. And so you can by accommodating, it means you can have your focus go from distance to mid-range to near, really in a very fluid fashion in a young eye. So the reduced zonular tension allows the elastic capsule of a lens that's, again, gelatinous and young to contract and increase its curvature. When we get older, and I'm going through this right now with presbyopia, I have to tell you, it's like it's a rude awakening of getting older. The zonules of my lens, when they relax, the lens does not change its shape the same way it did 2-3 years ago. And what happens is that then the focus, no matter what your baseline focus is, there's no shift to near or mid-range. And so the lens has lost its pliability. And that is what's called presbyopia. There's other theories too, but again, this is the main one.
Thank you. I think that was a wonderful review, having not thought about the physiology of lens zonules in quite some time. So are there any accommodating intraocular lenses?
Yeah, I mean, the most popular has been the crystal lens, which has basically a flexible hinge at the haptic optic juncture. And what happens is, theoretically, when there is that contraction of the ciliary muscles, it causes the lens to then change in position in an antero-posterior fashion. So there's movement of the optic of the lens more anteriorly, which then increases its power. And as a result, can give you more of a reading vision. Now, I say theoretically because there's a lot of ifs about that. And initially when it was developed, it was really exciting and a wonderful option. But there's a lot of limitations to it. And in my practice, I would say it works unpredictably because the sizing of that lens in an eye, white to white distance can affect how much movement there is, contraction of the capsule around it, fusion of the capsule around those hinges. If the hinge is not positioned the right way in the capsule, there's a lot of kind of details around making that work. So yes, the answer is yes, there are accommodating intraocular lenses, the crystal lens being the most popular or the one that's available, at least in the US. But it's not as predictable as we'd like it to be. There's some more in the pipeline, and who knows, maybe in the future, there'll be ones that are much more predictable.
Can you help explain the difference between monovision and mini monovision, and then kind of walk us through how you determine which patients are good candidates for monovision, and then how you have those discussions with patients before they go to surgery to determine who's a good candidate?
This is a great question. So monovision is essentially having your dominant eye. Most of us have a dominant eye, and by dominant eye means that we preferentially use that eye without really knowing that we're doing that for distance. And back when cameras didn't have a digital screen, it was easy to kind of determine based on, okay, which eye do you hold the camera in front of when you're taking a picture? This is old style cameras that had a peephole through them. And typically that patients would say, right or left, and that tended to be the more dominant eye that the patient had. There's other ways of checking which eye is dominant. So the dominant eye is then focused at distance for monovision, and the non-dominant eye would be focused at near or mid-range, depending on where the patient's preference is. So monovision tends to be a difference in power. So plano for the dominant eye, focus at the distance, and the non-dominant would be somewhere between -125 to about -250. And that all depends on, again, patient's preference. If a patient is tall with long arms, it would be on a lower end of that range. If they are shorter with shorter arms, they're holding things closer to their eyes, so it would be closer to the 250. But it also has a lot to do with how much difference or anisometropia that patient can tolerate. Some people who are lucky enough are born this way. If they have natural monovision, then it's they can tolerate a lot more anisometropia. But if you're creating it artificially, it needs to have been tested when the patient has had good vision. So in a cataract patient, such as the one we're talking about, it's really tough to really discuss monovision with them when they have such decreased vision due to cataracts. So ideally, you would want to have a patient who comes in with a history of monovision, possibly with contact lenses in the past, before you then recommend it with cataract. You also mentioned mini mono. So mini mono, again, is the same concept, except the near or the non-dominant eye is more kind of targeted at the mid-range. So it could be anywhere between target of -75 even to -125 to capture more of the intermediate zone or the computer distance. Now, monovision can affect depth perception and stereopsis. So patients need to understand that. And again, if it was a natural monovision, in those rare cases where they were born that way, or in some cases, if there's kind of a asymmetric cataract that develops and a nuclear cataract develops in their non-dominant eye, causing a very slow myopic shift in their refractive error before the vision gets significantly deteriorated as a result of the cataract, they can get accustomed to that kind of increased monovision refractive status. That's kind of the general idea. Discussion around monovision is difficult. It's unless, again, the patient had tried it as a contact lens user. And that's not uncommon that patients nowadays, especially with optometrists, really focusing on giving patients what they're demanding, which is spectacle independence. And so many patients now in their 40s are working on the computer. They're really demanding having that kind of spectacle independence. And optometrists are working with patients with monovision contacts.
That's extremely helpful. And this patient obviously never had monovision and didn't really have experience with whether or not this would affect his depth perception. So he was particularly interested in multifocal lenses over monovision. What is the difference between multifocal IOLs and extended depth of focus IOLs? Do you use both types of lenses in your practice? Do you find that some people favor one over the other?
Great question. And actually a discussion that I have with, senior surgeons. So this is not only relevant to, your stage and what you're doing, but I have to tell you, this is a very hot topic for all of us because it's constantly evolving. There's so many wonderful options for patients, and being able to make patients to the right lens and anticipate their success is one of the challenges and kind of art of medicine that I think with experience, I've become more and more comfortable doing. So there's two major types of multifocal IOLs, the zonal refractive and the apodized diffractive. So zonal refractive lenses use kind of a change in refractive power from the center of the lens to the periphery to provide the distance and near correction. And zonal refractive are more dependent on pupil size than zonal refractive lenses are more dependent on pupil size than diffractive lenses are. And it's understandable because, again, as mentioned, the zonal refractive, the different areas on the lens have different refractive power. So if the pupil is blocking the peripheral part of the IOL, then those refractive powers that are represented in the periphery of the lens will not be utilized. Now, a diffractive lens uses a series of concentric rings to form a diffraction grating, and that creates two separate focal points for distance and near. It's very complicated, so much so that please don't ask me to explain that any more clearly, except to say that there's a lot of resources to go to. And essentially what this does is, I guess the best way for me to describe this, and I use this description for my patients, is that the multifocal lenses that with the diffractive lens technology, they split the light and make it such that there are two focal points of focus. And when you're looking at near objects, as well as distance options, without you knowing that there's two separate focal points, you can have a focus at the different distances. Now, the multifocal lenses, the previous generation, and they're still obviously available to us, there's mostly were bifocal, essentially. So there would be like different add powers, so that there would be a lens with a higher add power to it, and that you would use in someone who wants great distance vision and also really good near vision, but it would kind of have some weakness in the intermediate and mid-range. There's ones with lower add power that would be more for someone who wants to be able to work on a computer and then have great distance. And we would sometimes do mix and match. And this is, again, where kind of the art of being able to make patients to the right lens would come into play. With the current technology, multifocal lenses, the trifocal lenses, two of which I use in my practice. So the two trifocal lenses that I use in my practice are the Synergy and the Panoptics are the two that have been approved in the US, and trifocal lenses, which kind of takes away that complicated discussion around mix and matching and, which distance do you prefer, middle or near or distance. That the trifocal, like the name says, essentially gives you excellent reading, mid-range, which is computer, dashboard, and distance. And that's essentially the multifocals that in my practice work really well. As far as the extended depth of focus lens, the Symphony was the first of its kind. And essentially the extended depth of focus lens, it's a new category with the Symphony lens. What that lens does, it stretches the kind of the defocus curve of a lens and the distance at which it utilizes the most amount of light and does the focus. An extended depth of focus lenses tend to have better nighttime kind of visual aberration profile and more of a fluid focus where you don't have to search for that right sweet spot for your vision, at least theoretically. For many patients, those work quite well, but some don't. And that's, again, where the challenge is. There's now also the Vivity, which is in that extended kind of depth of focus type category of lens, which again, it stretches the defocus curve, or stretches the focal point of your vision so that you have excellent distance and mid-range. So from distance all the way to computer. Did I answer your question there?
Yes, absolutely. I'm even learning so much right now because these are complex topics and each lens has its nuances. So this is really wonderful to go through all the different types. So moving on to the next question, how do you choose the best patients for multifocal lenses? Are there certain conditions that make a patient a poor candidate, or patients that you would exclude from considering a multifocal lens?
Well, this is the $1 million question then. We're going to try to cover it really quickly here. There's a huge challenge about this, as you said, as we were talking about. I mean, this is probably the one of the more complex topics among cataract surgeons. How do you choose the best patient for each type of advanced lens technology we have? I tell you, when I was a resident, we only had monofocal lenses, and it was so easy. The chair time was minutes, and it didn't really take much time to have that discussion around patient lifestyle, what their needs are, and also patients didn't have those demands that patients now do have. Now, was it easier? It was easier back then. It wasn't as fun. It's a lot more fun now, trying to do our best to not only improve patients' vision, but also improve their lifestyle and optimize their lifestyle and their visual abilities. So what it requires is for you to develop a kind of a real understanding of who that patient is in the short bit of time that you have doing that consult. And much of that comes from your training your technicians in getting a really nice history. What does the patient do? For me, the vocation is really important. If I have a patient who's a photographer, who is, a pilot, who is an engineer, the discussion is very different than someone who doesn't drive because they have other disabilities. So, again, this could be an hour-long discussion around how do we fine-tune that matchmaking potential. I joke to my patients and I say, look at me as a matchmaker. I'm going to matchmake you with the right lens. So the comprehensive discussion is really important about what the patient's day-to-day life. So what I usually ask the patient, the question that has helped me a lot is, tell me how you use your eyes. And it's important to understand, is this someone who gets up in the morning and from the minute they're up, they're putting on their glasses until the minute they go to sleep? Or are they the kind of the low myope, the -2 myope who doesn't put on glasses until they leave the house? That's a whole different discussion and whole different type of patient than someone who absolutely demands excellent distant vision and doesn't mind wearing reading glasses, for example. Or someone who is coming in with cataracts, bitterly complaining about their decreased vision and glare at night, but you look at their eyes and you manifest them and they're 20/20 minus, like they miss one letter on the 20/20 line, and you look at their cataract and it's mild and they're complaining of glare and halos and there's no other reason, no dry eyes and nothing else. That is not a patient I would recommend a multifocal in, and I explain it to them. I tell them, look at how you're bothered by your 20/20 cataract. I can bet you that you will not enjoy the visual aberrations in the nighttime rings around lights that you'll get with a multifocal lens. So comprehensive discussion about the lifestyle, about what they do, what their expectations are. Is this a patient who comes in adamant about, I don't want to wear glasses and it'll be a failure if I have to wear reading glasses, or it'd be a failure, doc, what's the chances I'll have 20/15 vision? If this is a patient who comes in demanding 20/20 vision, then you need to really sit down and make sure that their expectations are realistic and that you're offering them the lens that meets their demands. The EDOF versus multifocal discussion. So let's talk about the classic ideal multifocal patient would be someone who has come in with less, with a vision that's less than 20/30 due to their cataracts, and you ask them, and you look at their cataract and you're thinking, oh my gosh, this is bad cataract. How are they even reading the 20/30 line? And you look at their eyes and you ask them, what brought you in? And they say, well, I kind of started noticing at nighttime, I'm not seeing the street signs. Or, when I'm driving, I'm just barely noticing it. That's a patient that even if they have hesitation about the multifocal lens, I'm like encouraging them to dive in, because obviously their demands on their optical system is not so precise that they're noticing that cataract at a time when someone else may, many of other patients would notice it. It's also the right choice for a patient who wants to have independence from glasses as much as possible. And, it's important to discuss that at night when you're driving, you may get rings around lights. If you use the word glare and halos, they tend to cringe, because that's often why they came in the first place. Their cataract was causing them glare and halos. So the word glare and halos tends to discourage patients in considering a multifocal lens. I mean, as you can tell, there's a lot more to it than just that. Now, who are poor candidates for multifocal lenses? It would be a patient who has other comorbidities that impact the optics of their eye. And the reason that's important is because of twofold. One is the multifocal lens, as we mentioned, splits the light. And so you are utilizing less light at the different distances of your vision. And as a result, if the contrast is slightly diminished in a healthy eye. But if you have an unhealthy eye that has other comorbidities already jeopardizing the contrast of that eye, the contrast capabilities of that eye, such as dry eyes that is not responsive to basic treatment, irregular astigmatism, macular degeneration, advanced glaucoma, corneal scarring, any of those things, it can obviously compound the problem if you implant a multifocal lens in those eyes. Now, I think and the other problem with that is that a patient who's investing in a multifocal lens, they're doing it because they want to have independence from glasses. Well, it'll be harder to deliver that promise to them if they have other comorbidities. And so in those cases, if the patient has dry eyes, for example, who responds to dry eye treatment that you initiate upon your cataract consultation, that's fine. That patient can get a multifocal lens as long as they understand that they need to maintain their ocular surface health when that lens is still in their eye. Other more permanent problems, like I mentioned, irregular astigmatism, macular degeneration and such, well, I really try to avoid multifocal lenses in those eyes. Now, the extended depth of focus lenses, on the other hand, especially the Vivity, which doesn't have the concentric, doesn't have as much impact on the contrast of the vision. And it actually in the studies was shown to have monofocal quality vision. So kind of mimics the same vision one gets with a monofocal lens. Those lenses can be implanted in eyes that have mild comorbidities. So mild epiretinal membrane, mild macular degeneration, with the patient understanding that it's difficult to anticipate how much they will be able to reap the benefits of the extended depth of focus lens, but at least you can be assured that you're not going to lessen the contrast of their eye. So that's kind of the general gist and a very shortened version of probably a 2-hour discussion.
I think it was a very succinct summary. Do you think you could walk us through some of the surgical pearls for early practice cataract surgeons that are interested in using multifocal lenses? Is there anything that they need to be more mindful of in the OR? And then any postoperative complications? I know you mentioned glare and halos and things like that, but is there anything else that we're more careful about in these patients?
Most of the pearls for success with multifocal lens really comes in determining who's the right patient. So I think the discussion we just had is probably the most important part of success. with multifocal lenses, making sure the ocular surface is healthy, looking at the corneal topography and corneal imaging, making sure the optics of the eye will allow for it. Looking at the macula with with OCT. I make sure you do a topography and OCT on all your premium lens patients. The patient expectations are accurate, all those things. And then the biometry. You want to make sure your biometry is as accurate as possible. And those, the biometry can be impacted not only with the ocular surface and irregular astigmatism, but also just the formulas you use and such. So I would say working towards adding multifocals to your practice, you have to make sure that you understand patient selection and optimizing ocular surface and ocular health of the patient, and also fine-tuning your calculations and your surgical adjustment of your lens power. As far as surgical pearls are concerned, create an incision that's peripheral and has minimal impact on your astigmatism, making sure that you polish the capsule. I polish the capsule on all my patients regardless, but I maybe spend a little extra time on my multifocal patients because I want to minimize the risk of PCO formation and contraction of that capsule, making sure that your capsulotomy is centered so that that lens optic stays planar and doesn't get a tilt to it. At the end of the case, what I do is I change the light on my microscope to get a single light or two lights so that I ask the patient then fixate on the light, and I try to center that multifocal lens, the center of the multifocal lens on their visual axis. I mean, I haven't done a study to see if that actually makes a big difference, but it does make me feel better at the end. And that's essentially it. And, minimizing inflammation. So using any way possible, minimizing inflammation or early inflammation in that eye, and hitting your target as best as you can. So that formula is important, and the surgeon adjustment is very important in those patients.
And then finally, with the recent approval of a presbyopia drop, where do you think it would fit in with a cataract and refractive practice? Have you had any experience with the drop? And what are you looking forward to in the future?
Yeah, I think the new presbyopia drops are really exciting. I mean, there's one that's been approved, which is AbbVie's or Allergan Vuity, which has really, initially, as surgeons, we were wondering if it's going to have much of an impact in our practice, but there's absolutely a role in it in a surgeon's practice. And probably the most important role will be in the refractive surgical practice, which is patients coming in who had LASIK previously, who are emmetropes. Their distance vision is not impacted, but they're coming in their early 40s, mid 40s, complaining of difficulty reading. And those are patients we really didn't have very, very good options for. And now with the presbyopia drops, there'll be a lot of opportunity. I'm sure you can do a whole podcast on that. And then in the cataract surgical practice, I think in patients who have multifocal lenses implanted in their eye, and they're happy with their vision all around, except maybe nighttime glare and halos or nighttime aberrations, the presbyopia drops may help with that. Or if they have extended depth of focus lens that doesn't give them enough reading, we anticipate that some of the presbyopia drops can be helpful in increasing the depth of focus in these patients. So time will tell. I think with more experience, we'll be able to really kind of see where the sweet spot will be for these drops. But I as a pre or early presbyope, I'm very excited about these drops.
Thank you so much, Dr. Shamie. So let's summarize what we learned today. Presbyopia is the normal loss of accommodation that begins to occur during middle age and is explained most commonly by the Helmholtz theory of accommodation, though there are other theories, and you can read about those in our major textbooks. Non-accommodative surgical treatment for presbyopia is most common and includes things like multifocal IOLs and monovision. Monovision involves correcting the non-dominant eye to be slightly myopic, but you have to remember that in patients that you're choosing monovision, there may be a slight decrease in stereopsis. Multifocal and extended depth of focal lenses can be refractive or they can be diffractive. The decision to pursue multifocal lenses is complex, as we heard from Dr. Shamie, but this is a wonderful way to optimize the visual function for our patients. Surgical considerations for patients that you choose to pursue multifocal lenses include having a peripheral incision in order to reduce astigmatism, polishing the posterior capsule in order to avoid posterior capsule opacification or capsular contraction, and trying to center the lens on the Purkinje reflexes of the light to make sure that your patient has the best visual outcomes. There are options for patients that are not quite ready for cataract surgery, but are still interested in presbyopia correction. And you should stay tuned for more on this during another episode of the Pupil Pod. Dr. Shamie, before we end the episode, I ask all of my guests an icebreaker question. Now, I have asked a few of our guests this question before, but I'd love to hear your answer. If you could have dinner with anyone from any time in history or that you've known in your life, who would it be?
It would be without a doubt Rumi, who is an ancient Persian poet whose poetry I have loved and study and use for my as life lessons. And I know that Sila, you too are a big Rumi fan.
I really, truly am. I think that Rumi's poetry and wisdom really got me through some of the most difficult times in my life and still help to hold that beacon of light through the darkness whenever I need it. So thank you for that answer. And thank you, Dr. Shamie, for leading us through this episode of the Pupil Pod.
It's my pleasure. And thank you so much for having me.
And thank you to our listeners. See you next time on the Pupil Pod.